Welcome to your Harvey class. We're going to be working today with Harvey, who is a fully functioning cardiology physical diagnosis mannequin. Harvey can do quite a few things, and I'm going to walk you through that. To start with, we're going to go through the 5 basic things that you have to do with any cardiac physical exam. Number 1 is the general appearance. Unfortunately for Harvey, you can't do anything with that because he always looks exactly the same. But when you're seeing a cardiac patient in the emergency room, you need to look at the patient, see if they're sweating, pasty, if the head's bobbing up and down, are they cyanotic, etc. And that may give you some clue to the diagnosis. The second thing we're going to talk about are the neck veins. The third thing is the carotid or other kinds of arterial pulsations, then the precordial movements, and then finally auscultation. I expect that as you do this, you get in the habit of the ritual of doing this, so you should do these things in the same order every time. Physical appearance, venous pulsations, arterial pulsations, precordial movements, and auscultation. If you do this, you'll become very skilled at the cardiac exam in a short time. We're going to talk now about the jugular venous pulses. As you can see on Harvey, he has some fairly pronounced jugular venous pulses. The jugular venous pulses will tell you about what's going on in the heart, particularly on the right side of the heart in the right atrium, because there is a direct connection between the right atrium and the jugular venous pulse with no valves in between. This is a sneak peek at what's going on the right side of the heart. There are 2 things that we want to notice with the venous pulses. First, we want to measure how high the pulses are, and that gives us an idea of the pressure on the right side of the heart. The second thing is the actual waveforms. I'll show you the waveforms here in a minute. As you can see here, I'm going to exaggerate this a bit and see Harvey's neck veins. In this case, he has exaggerated V waves, and we're going to talk about the AC and the V waves in just a minute. The way that you measure the height of the jugular venous pulses is that you look for the top of the meniscus, and in this case, it looks like it's somewhere around up in here, and then you draw a parallel line to that and then down to the sternal notch. So the sternal notch is always 5 centimeters above the left atrium, and say the neck veins were about here, you would have to add another 5 centimeters to those neck veins, so that would mean that they would be approximately 10. Normally the neck veins have 3 positive waves, an A wave, a C wave, and a V wave, and 2 negative waves, an X descent and a Y descent. The A wave is caused by atrial contraction, the C wave is the closure of the tricuspid valve, and the V wave occurs during ventricular contraction. It's a venous filling wave of the right atrium. So V can either stand for venous filling or ventricular contraction. If you're timing these, the A wave will occur with atrial systole and the V wave will occur with ventricular systole. You actually won't hear your heart tones until over here when the ventricle starts. Actually, you should hear them right here at the first closure sound, and then the second sound right in here. So those are the AC and the V waves. In certain circumstances, the A wave can be exaggerated. Usually, when the A wave is exaggerated, it's because the atrium is contracting against pressure, so you have some pulmonary hypertension or some back pressure in the pulmonary artery or the right ventricle. The V wave is usually exaggerated if the tricuspid valve is incompetent and you have backflow during that time. There is a situation called Canon A waves, and Canon A waves are a way of diagnosing that you have complete atrial ventricular dissociation. So if you have a 3rd-degree heart block and the atrium are beating at their own rate and the ventricle is beating at its own rate, the atrium are going to sometimes contract when the tricuspid valve is already closed, and you'll get a huge A wave, but it will be erratic and won't be regular like a large A wave will. We're going to go back and show you some large A waves and large V waves on Harvey. Now, I've talked to you about the AC and the V waves, so now I'm going to show you what those look like on Harvey. This is Harvey in his normal configuration, and you can see his neck veins, which you see right down here. It's going ACV, 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 ACV. And those are normal A waves, C waves, and V waves, and normal X and Y descent. So now I'm going to change it and show you a patient that has a large A wave. ACV, 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 ACV. So you notice how the A waves are exaggerated there compared to the C and V waves, which are fairly normal. Okay, contrast this to a patient that has large V waves because they have an incompetent tricuspid valve. ACV, 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 ACV. So you can see that the third wave in this is the large one. If you're confused, maybe the patient's heart is going fast and you can't tell whether it's an A wave or a V wave, then you can listen to the heart tones or feel the pulses. The pulse should be occurring at the same time as the V wave. The next thing we're going to talk about are the arterial pulses, and each of these physical findings give you some hint about what's going on with the heart. The arterial pulses are going to tell you about the left ventricle and the aortic valve because they're occurring on the aortic outflow tract. So we're going to go over the board here, and I'm going to show you a couple of different pulses, and then you're going to get to practice on Harvey to feel what those feel like. You might want to feel your own pulse to see if you can tell this, but a normal carotid pulse is felt just inside of the sternocleidomastoid. It has a fairly quick upstroke, then a thing called a dicrotic notch when your aortic valve closes, and then it falls down. So every cycle should feel somewhat like this, and that would be normal. The first pulse that we're going to show you on Harvey when you have a chance to practice is one that is slow and late. So in Latin, that's a parvus et tardis pulse, and that occurs with aortic stenosis. If you want to know that the pulse is late, then you can listen down at the apex, and the heart tones are occurring well before the pulse is. It also just feels like it's coming up slowly underneath your fingers, and there's not much of a pulse that you're feeling. So that's a parvus et tardis pulse, which goes along with aortic stenosis. The other aortic problem that you can see is one where it's an exaggerated pulse that gets up too high, and that's called a water hammer pulse, which you see with aortic insufficiency. The pulse goes up too high and falls off too fast. In a patient with severe aortic insufficiency, they may actually have their head bobbing while you're looking at them because of this strong pulse that they're getting. So that's a water hammer pulse, or a pulse of aortic insufficiency. Finally, there's one other pulse that you can detect on Harvey, and I'm going to have to erase the water hammer to show it to you. But this would be a bifid pulse, and it is somewhat hard to tell the difference between the water hammer and the bifid pulse because they feel similar, but I think you can get it with some practice. But a double pulse or a bifid pulse occurs in patients that have a hypertrophic cardiomyopathy. Their pulse goes up, they have an obstruction, they overcome the obstruction, and then have a second pulse. So you can have normal pulses, parvus et tardis pulses, water hammer pulses, or bifid pulses, and we'll try to show you all those on the Harvey. And now we're going to talk about precordial movements. Precordial movements are when you feel an area of the heart on the anterior chest. You look here at the heart laying on the chest, we're going to be doing a couple of precordial movements. So we're going to be feeling for the PMI, we're going to feel for a right ventricular lift, and we're going to feel for a pulmonary tap. If you look here, The only part of the left ventricle that you can actually feel is the apex, which is also the PMI. And so the PMI is important for telling you about left ventricular function. If you have a problem with the right ventricle, you're going to feel that over here on the right side of the chest. If you notice, the right ventricle is anterior, and so when it gets dilated or there's too much pressure, you can feel it pumping up here. You see here the pulmonary artery taken off in that direction. So where we're going to feel the pulmonary tap is second interspace, which is where that artery takes off, and you feel a pulsation right there in between the ribs. Okay, so when you're examining the heart or examining the patient, you always do it from the right side of the patient. And the first thing you do is you put your hand over here to the side, because sometimes patients will have their PMI way out here in the anterior axillary line or the mid-axillary line, and so you have to start there with your hand, and I put my whole hand down on the chest, almost like you were doing a push-up. Make sure you use the whole surface area of your hand to feel something. Now I can feel the PMI right now under this part of my hand, so I'm going to pull back, and the PMI is right here. I think you can almost see my middle finger bobbing up and down there. You remember, a PMI is a location. So it's going to be in the 1, 2, 3, 4, 5th interspace. It's near the midclavicular line. So that gives you an idea of where it is. You can have sternum, midclavicular line, anterior axillary line, mid-axillary line, and then your interspaces all go like this. So you have to remember that when you're giving somebody the location. When you talk about the PMI, it needs to have 2 bits of information. One is, where is it? And 2, what did it feel like? A normal PMI is about the size of a quarter. It's a single beat. So you see my finger kind of going up and down there where that PMI is? So it's a single beat, hits your hand and moves off. If it hits your hand and stays, that's called a lift or a heave. Now sometimes the PMI will actually have more than one component. So if you actually feel things like a 2-component PMI, then it means that you have a palpable gallop. You should have an S3 or an S4 in that situation. You may have an S3, S4 and a lift, so you need to be able to describe that. Okay, so that's the PMI. So I start out here, putting my hand on Harvey. I come back, I find the PMI, I get the location, what kind of PMI is it, and then the next thing I'm going to do is turn my hand around right here, put it next to the sternum on the right side, and what I'm feeling for is a right ventricular lift, which would be underneath my hand here, and then finally I'm going to go from the first interspace, find the rib, find the second interspace, and feel right there. You notice how I have my fingers kind of pointed down. I'm going to be feeling for a pulmonary tap. And that's basically how you do the precordial movements. I'm going to show you a couple of abnormal precordial movements so you can get the idea of how they are with more than one component. Okay, this is a patient with a cardiomyopathy, and you can see this PMI is pretty much lateral. It's at the anterior axillary line. It's almost in it's a 6th or 7th interspace. So you have a big dilated heart out here, and you can see it has 3 components. And one of those components is long. So that long component is a left ventricular lift, and the other 2 components are probably an S3 and an S4 gallop. So if you're feeling for this, and you put your hand way out there, you notice, oh, I feel something out here. It's fairly large. This thing is, much larger than a quarter, and it has 3 components. And you're going to think in your head the patient probably has a fairly diseased heart. And moving over here, you put your hand right here. You can feel that there's a right ventricular lift right here. And it's 3 components as well. And finally, moving up here, first interspace, rib, second interspace. I don't think this particular one has a pulmonary tap, but this is where you would feel a pulmonary tap if it was present. Finally, we're going to talk about auscultation of the heart. You notice that we have done all this physical diagnosis of the heart, and we have yet to put our stethoscope on the chest. When you're doing your listening of the heart, it is very easy to get confused if you haven't done the first 4 steps. But if you have done the first 4 steps, you already know enough about the heart, you sort of know what kind of things you're looking for. When I'm listening to the heart, I like to break it down into individual segments. That way you don't miss things that are potentially important. So the first thing that you're going to do is you're going to do S1, S2. Normally, your S1 is a single sound. Occasionally it will be split. Occasionally you'll have an opening click or an opening snap, but usually S1 is a single sound. And then S2 is a single sound when the patient has exhaled, but when the patient breathes in, because that pulls more blood in onto the right side of the heart, the pulmonary sound will be a little bit later, and then so you'll hear a split S2. So it goes something like this. Bump, 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 blum, bump, blum, bump, blum, bump, 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 blum, bump, blum, bump, blum. So when you're listening to Harvey, try to make sure you can hear the splitting. Occasionally, you will hear the splitting to be really wide if you have something like a bundle branch block or you have a left or right shunt. The next thing that we're going to add in are some gallops. And gallops occur for 2 different reasons. And S4 gallop occurs because you have some left ventricular hypertrophy, the ventricle is stiff, and the atrium is contracting blood against the stiff ventricle. It occurs just before S1. You hear gallops better with the bell than the diaphragm, and you hear them predominantly at the apex. You cannot hear gallops very well up at the base of the heart. If you're hearing something up there, it's probably an ejection click or something else. The mnemonic for an S4 is the state Tennessee. You go Ten-na-see. So it's ba-da-dum, ba-da-dum, ba-da-dum. Tennessee, Tennessee, Tennessee. All right? Then, for an S3 occurs because you have a dilated heart that doesn't empty well. So you have blood still in the heart more than you normally would have. The atrium starts putting blood in there, so you have blood hitting blood and it makes a sound. And this is usually what occurs when patients are in heart failure. Of course, occasionally it will occur in normal patients. In fact, the normal patient here has a slight S3, but most of the time this is because of volume overload. And the mnemonic for this is Kentucky. So it goes Kentucky, Kentucky, Kentucky. So if you're timing it out, you get all those in there. Now sometimes the patient will have both an S3 and an S4, and the mnemonic for that is Connecticut. So there's So just use the states and you should be able to time these things out. Start out with S1 and S2, listen for the splitting, then listen for the gallops before you start looking at the murmurs. Now we're going to talk a little bit about the murmurs, and I think there's 4 basic murmurs you need to learn. There's several other variations on those, but I think if you learn these 4 basic murmurs, you'll be able to pick up most things, particularly if you're doing a good job of the rest of the physical exam. So the first thing that you have to be able to tell is an aortic stenosis from aortic sclerosis murmur. And most aortic murmurs start somewhere after S1. They occur during systole. It's a crescendo decrescendo murmur, meaning that there's an up phase and a down phase. And so it'll be something like this. So the murmur will go up and down. That's a typical aortic sclerosis murmur. The carotid pulses will be okay. The murmur will finish right around or just before S2. S2 should be okay. And the murmur will peak pretty early. It's not going to peak late. The later the murmur peaks and the more that it obscures S2, the more likely it is to be an aortic stenosis murmur. And you also need to be checking the carotid pulses, as we mentioned before. So a bad aortic murmur is going to peak later and probably be a little harsher. It doesn't necessarily mean it's going to be louder, but it's going to be more like where it goes up, and then the down part is much shorter than the other type of murmur. Okay, we're going to move on from that. So we've got aortic stenosis, aortic sclerosis. The way you describe this on your physical is that the patient had a crescendo decrescendo murmur, and particularly how loud it is, and you need to look at your handout to get the gradings on how loud it is. Murmurs that are crescendo decrescendo also occur when you have a fairly high pressure chamber in the heart, like your ventricle pumping blood to the aorta, which is also a high pressure chamber. That's why the murmur has to build up, because it has to build up enough pressure on both sides of the valve. The second thing, murmur we're going to talk about is what's called a holosystolic murmur. Now, a holosystolic murmur does not mean that it just occurs in systole, because I just told you the other murmur occurs in systole as well. And I really want you to make sure that you use your terminology correctly. Don't just call every murmur that you hear in systole a holosystolic murmur. Holosystolic murmur means it starts at S1, it goes to S2, and it's fairly the same all the way through. And this is going to be a high pressure chamber in the heart pumping blood to a lower pressure chamber. So you've got a VSD where you're pumping blood from the left ventricle to the right ventricle. You've got a mitral insufficiency murmur where you're pumping blood from the left ventricle to the left atrium, or you've got a tricuspid insufficiency murmur where you're pumping blood from the right ventricle to the right atrium. Those are both high pressure chambers going to low pressure chambers. So the murmur starts at S1, goes to S2, and it's the same all the way through. So these are kind of like this. Murmur is the same from beginning to end. Okay, next we're going to talk about a couple of diastolic murmurs. The first one of these is going to be aortic insufficiency. So we already talked about the aortic murmur coming up here. If the valve is insufficient, the murmur is going to be a diastolic decrescendo murmur that starts right after S2. Now, a lot of times there'll be a little bit of a flow murmur before it because there's some turbulence. And so what you're going to get is you're going to get a murmur that starts at S1, S2, and then it kind of sounds like it's heading away from your stethoscope. You actually hear this best from the pulmonary area down to the tricuspid area along the left sternal border. And it goes something like this. And where that is, and that murmur is going away from you, is the murmur of aortic insufficiency. All right, and then finally, you have the murmur of mitral stenosis, which was fairly common when patients had a lot of rheumatic heart disease, but since rheumatic heart disease is rare now, you may not hear this very often, but it is you have an opening snap, and the murmur is a diastolic crescendo murmur, and so it kind of goes where it's kind of building up in diastole to the S1 and then to the S2. So those are the basic murmurs that you need to know. So remember, listen to your S1, listen to your S2, then listen for gallops, then listen for the murmurs. And I think your faculty will be able to walk you through the rest of it.